1 in 4 men starting testosterone therapy today does so without ever receiving a blood test to confirm a deficiency. Between 2000 and 2013, testosterone sales entered a period of rapid growth. Direct-to-consumer marketing shifted the focus away from clinical necessity and toward promises of increased energy, weight loss, and a reversal of the aging process. Each 200 mg per milliliter vial of testosterone represents a potent pharmaceutical intervention capable of altering the function of nearly every system in the body. This massive surge in prescription volume has placed millions of men into a state of unmonitored hormonal flux, detaching a powerful medical treatment from the specialized oversight it was designed for. The marketing language of low-T clinics is often at odds with the rigorous diagnostic standards maintained by the American Urological Association and the Endocrine Society. The clinical baseline for a legitimate diagnosis requires 2 separate, early morning fasting blood tests consistently below 300 nanograms per deciliter. These markers must align with specific physical signs, like unexplained anemia or bone density loss, to confirm true hypogonadism. Without meeting these strict criteria, men are manually overriding their endocrine systems without a clear medical reason to do so. The biological response to therapy depends on the delivery method: topical gels, subcutaneous pellets, or intramuscular injections. Exogenous testosterone works by suppressing a protein called hepcidin. Because hepcidin regulates iron and blood production, suppressing it signals the bone marrow to drastically ramp up the creation of new red blood cells. This chart from the Prostate clinical study shows the rate of erythrocytosis, a condition where the blood becomes dangerously thick. For users of topical gels, the rate was 12.8%, while those using pellets saw an increase to 35.1%. However, for men using intramuscular injections, the rate of blood thickening jumped to 66.7%. Blood of this viscosity significantly increases the risk of clotting. Patients on these injection protocols frequently require therapeutic phlebotomy, the medical removal of blood, to keep their circulatory system within safe limits. The choice of delivery is more than a matter of convenience. It is the variable that determines whether the hormone remains therapeutic or becomes a cardiovascular risk. For decades, medical practice was shaped by the fear that providing testosterone was like pouring fuel on undetected prostate cancer cells. Modern research points to the saturation model. A prostate cell has finite androgen receptors, acting like docking slots. Once every slot is occupied, the cell is saturated. Additional testosterone cannot dock and simply washes past without stimulating further growth. As the historical fear of prostate cancer has receded, the medical community has shifted its focus to a different, more complex variable: the heart. In 2013, conflicting data regarding heart safety led the FDA to conduct a wide-scale review of the testosterone boom. Some retrospective studies indicated that testosterone therapy increased the risk of heart attacks, while other evidence suggested that normalizing levels actually protected the cardiovascular system. To resolve the conflict, the FDA mandated the TRAVERSE study. Led by institutions like the Cleveland Clinic, this is the largest randomized trial ever conducted to measure major cardiovascular events in men on testosterone. Until these long-term results are fully analyzed, the impact of supplemental testosterone on the aging human heart remains one of the largest unresolved questions in modern medicine. For men with a clinical diagnosis of severe hypogonadism, the benefits of therapy are well documented: restored bone density, improved metabolism, and stabilized mood. But for the millions of casual users seeking a shortcut to vitality, the risks are high. Suppressing natural hormone production can lead to testicular atrophy, elevated estrogen, and dangerously thickened blood. The severity of these side effects is dictated by the delivery method, specifically the violent spikes in hormone levels caused by injections compared to the steady release of gels or pellets. Testosterone is a finely tuned biological lever. Pulling that lever triggers a chain reaction through complex, interconnected machinery that most users never see.